So yesterday we covered how to handle our instruments. So thumb, ring finger, middle finger on the angle, index finger on the shank, and holding needles two-thirds along the body. So you have the point, the body, and the swage end. You mount it two-thirds along the way at the very, very, very tip of the needle holder. That way you have more flexibility. We talked about the palm grip and the standard grip. You don't want your fingers to slide down because you lose flexibility, and it's a rotating movement. We talked about interrupted suturing, mattress sutures, and closing wounds temporarily, which are under tension, and how to tighten a knot with a slip knot and a reef knot. Um, we're going to cover wounds under tension today. So that's by putting deeper sutures in. So when I think about wounds under tension, you have techniques to close the wound, but you also have the sutures you select to help. If I've got a wound that's gaping like this, and maybe the patient's got thin dermis because they're elderly, and we know that every 10 years you lose about 6% of your dermis. So if they're in their 70s, they would have lost a reasonable amount of that dermis. I want to pick a braided suture because it has more grip. I want to start in the apices and work towards the middle. And I can do some maneuvers to narrow the space so that my sutures are more likely to hold. So the first thing I would do is put some temporary stitches in. And this is revisiting one of the techniques we used yesterday. I'm going to take a bite, grab it with the forceps straight away, mount it straight away. I don't like that sitting because I've damaged the skin pad there. So take a bite, mount it straight away at the very tip, continue. I'm just going to put a temporary suture in that will take off the tension into that wound. 2 revolutions as a surgeon's knot, finger, tighten the knot. I'm going to put my finger underneath. I'm going to hold it still, go under the loop, put it through. And it's just a temporary suture so that my wound closure of the deep space is not as challenging. For speed, you put all the instruments and the needle into your one hand. You haven't got an assistant to cut for you. You open, you slide down, angle it, and you cut. If you're by yourself, you're going to be cutting a lot of sutures. Palm the scissor, covered this yesterday. You palm the scissor just to the side. It's an iris. If you put it there and you flex your wrist, you'll cause yourself a sharp injury. Just put it to the side, and then you can carry on suturing. So now we're going to do our deep dermals. So we talked about yesterday how to classify sutures. We had non-dissolvable, dissolvable. So Picron, Ethibond is non-dissolvable. PDS, Vicryl, Monocryl is dissolvable, but you also have braided and monofilament. So this non-dissolvable suture is braided, it's got a couple of sutures intertwined, and this monofilament is dissolvable. It's synthetic. Synthetic sutures dissolve by hydrolysis. So I'm going to use a dissolvable suture, but I'm going to use a braided stitch. I'm going to use a long-lasting dissolvable suture, which is braided, and that's this Vicryl suture. So I'm going to start in the apices because, again, I don't want my suture to have to work too hard. I'm going to take a bite. Let's go a bit further down. Go from deep to superficial. Mount it straight away. I pull it through, and then I palm my instrument to get this angle. I'll zoom in on the next one, just so you can see my hand position to start with. You go in. Now, you typically are supposed to go in vertically, but you want to get a good amount of bite in the tissue. So I actually go in obliquely, not transverse, oblique from deep to superficial, so that I capture more tissue than I would if I was going to go vertically. I see my needle end, grab it with the forceps, pull it through, and then pull. I'm pulling in the direction of the wound because otherwise it will avulse out the tissue, and I leave the suture end slightly longer than I would if I was doing skin closure. Same thing as normal. Push the suture, 1, 2, but for this you tie parallel to the wound and close nicely. If I wanted to retension it, I can do the slip knot. The slip knot is pulling the short suture through the loop, letting the short suture come back to where it came from. I'm pulling till the wound reapproximates, and then when I'm happy, I pull the long, but the wound edges are already together, so not a problem. Alternate your position. It's a braided suture, so 4 knots, it's fine. And then cut flush. So you open, slide down, angle it, and cut. And it's just palming the scissor. So as you can see, I've done the apex on that side. Now I'm going to go to the apex on the other side. Now I'm going to zoom in so you can see a bit better what it is that I'm doing. Have you got any questions? That's very kind of you to say about the videos. We'll keep on going and keep on hoping you keep learning. And if you stop learning, it means that you've surpassed what I have to teach you, which is great. But then there's always the tendon repairs and the microsurgery. And then we're going to go from superficial to deep. So on this side, you always start on the side closest to you, deep to superficial, and then away from you go superficial to deep. I've palmed the needle holder. If you can see, I've already used the skin pad several times. So there's lots of holes in it. So I really want to make sure I've got good excursion in the tissue. I'm going to do it in 2 bites to make sure I'm in the depth of the tissues, which I am. And my needle's just down there. Got to be careful you don't blunt the thing or lose the thing, which I may have. I'm just going to reverse a little bit. So follow the curve. I'm just going to take it out and do it again. So it's slightly too deep for the size of the needle. So again, pick a needle that's longer. There. You don't want to pull too hard. You just want to 1, 2, pull it parallel to the wound. So in line with the cut. Yeah, my suture snapped, which is wonderful. So that can happen. So I'm gonna get another suture. See if I can use one that I've already used before. Go up here. Slightly longer needle, which is great. So let's go somewhere here. Deep to superficial. Follow the curve, mount it straight away, and pull. Leave a slightly longer end, like I said. I've palmed the needle holder. Rotate your wrist from prone to supine. You just want to stitch skin, you don't want to stitch fat. See your needle tip. And then 2 revolutions. So I'm going to tighten that again. The other thing is to make sure you're using a suture, which is the strength of it's going to help it's got the right strength. So the strength it takes to break the suture material is the number. So the other one I was using before was a 4-0. This is a 3-0, therefore it's stronger. And I now need to put a stitch either side of this. And so I'm just going to go in here, deep to superficial, see the needle tip, follow the curve, and then superficial to deep. And then once you've done this, you just need to start thinking about before you finish, you need to start thinking about what you're going to use to do the superficial closure. So whether you're going to do a continuous suture, a subcuticular suture, or you're going to do interrupted. As it's a long linear wound by the time you've finished, I think you should choose to do a subcuticular because it's neat, it's discreet, and done such a good job on the deep closure. Why leave stitch marks on top? So if you see, if I zoom out, we've gone from a big gaping wound to a nice linear wound. I need to put one more stitch either side. At this stage, I'm going to be brave, and because I've got some spare monofilament suture, which is also dissolvable. Actually, I have a braided dissolvable suture, but this one is violet. The reason why I don't tend to use this in skin suturing, so I use it for deep sutures like fascia for scalpel sutures in the abdomen or muscle, but I won't use it for skin is because it's violet and you can see it beneath the skin if you're too superficial. So typically, Vicryl, I'll use Vicryl, reverse cutting, undyed. The cutting refers to which side of the needle is cutting. So that's the face, the inward face. That's cutting if it's on this side, reverse cutting if it's on the back. If you have it cutting when you're suturing this way or this way, the cutting face is more likely to rip through the skin. If you have it reverse cutting, going at 90 degrees, and it's away from the wound edge. But in reality, if you're precise and accurate, it shouldn't really matter. So deep to superficial, don't want to be too superficial because it's violet and I don't want to see it under the skin. Got a lot of suture. The ripped skin pad, so I'm just going to catch the deep tissue, make sure I see it. I'm going to get caught in a loop, so I'm just watching that. Ooh. And sometimes when I've got a wound under a lot of tension, I'll actually hand tie it. So if I'm suturing the back and I'm using a 2-0 or 3-0 suture, I actually tend to hand tie those things because that way I don't snap the suture. So we'll cover hand ties after this, but the way I do a two-handed hand tie is you've got the short end and the long end. The short end is here, the long end is here. Now, although it's this way, I'm going to tie it this way because that's the direction of the wound. So short end comes up, long end comes down, bend the middle finger over the long, under the short, and squeeze. Aha, but it ripped out. That's okay. We'll place it again. Like I said, the skin pad has seen better days. We'll just do hand tying on the jig, but my point still remains. Go under my loop so I don't get caught in the loop again. And I pull. Let's see if we can do it. This. And then we need to go over. We need to go down. We're going to do a one-handed. So one-handed is just like this. But the going up is the same. The coming down is just between your thumb and middle. The suture long one comes up. You go over the long, push the short one back through the loop with the index finger and pull. Be careful you don't cut your knot. So go on, flush, and angle it. And then now we can do a subcuticular suture, but not before we cut out this suture and see how the wound looks. Great. So I've taken off all the tension. I'm going to do a subcuticular suture. I typically prefer monofilament suture all the videos we do tend to do the subcuticular buried stitch. So for a change of scenery, why don't we do the pull-out suture, the one that you just anchor at the top. And yeah, let's do that. So, so yeah, actually, if you've got a really well approximated, like perfectly approximated um, deep dermal, you could in theory, but you have to remember that the width of a patient's scar is dependent on how well you close that dermis to dermis and epidermis to epidermis. So if it's really well approximated, you could just put glue on it and then steri strips across it. That's perfectly reasonable. It's almost like you just made it a superficial wound. But if you ever think that you can get either the wounds under tension because it's over a joint or the patient's face where they're going to be smiling a lot, you're better off placing another layer to make it bulletproof. If you're worried about stitch marks and you think your deep dermal is good enough, then why don't you do a pull through subcuticular? And so that would start with going in the apex, coming out, and then that way you get the same effect of a subcuticular, but you don't get the stitch marks or a long-lasting suture inside the wound. It starts the same. You do the apices, or at least I start the same. I do the apices on both sides. Right in the corners. Get a good excursion through the tissues. The key to doing it quickly is to pull it with the forceps, mount it straight away, and then pull the suture. And then continue, go in opposite where you came out. Keep it nice and superficial. You want to get good excursion, so I pull the skin back, grab it with the forceps, mount it straight away. I pull. Maybe went too big with the first one, but seems to have approximated nicely. If you're worried you're going to pull your suture out, you can just place another clip on that side to give yourself traction. You want to make sure that your suture glides so that when it comes to pulling out, you know it comes out. And you go from, well, it depends how flexible your wrist is, but I go from a palm grip on the side away from me because my wrist isn't that flexible. So it's not about forcing the tissue through the skin, the needle through the skin. It's about guiding it through. So if it's not going, don't put more pressure, just angle it better. Quite a big gap in there. So actually, I put a deep dermal in that in reality in the middle. But for now, don't tend to leave things to chance. But the skin pad has seen better days, so I'm not convinced it will take a deep dermal. But let's say actually that's happened in real life where, you know, the dermis is completely obliterated, either due to you causing too much trauma to it. Just get an interrupted suture, non-dissolvable, and place it across it like the locking mattress. That would be perfectly reasonable. I wouldn't leave it to a subcuticular, which you're going to pull out in a few days. So again, this is a really good suture if you don't want to leave stitch marks, but you want the wound to have a bit of support for a bit longer than oh, so I quite like that. It's well approximated. You've got dermis to dermis, epidermis to epidermis, and the layers aren't overriding on each other. The beauty of this is that you don't have to put any knots in. And if you use the barb suture, You don't have to start outside. So Stratafix, it's barbed. So all you have to do when you get to the very end is go back on yourself a little bit and it will lock. You'd cut that flush and you'd cut somewhere flush in there. Yeah. So if it was the barb suture, you'd cut that flush, and that'd be it. Well, let's have a look. Looks good. Quite happy with that. So that's the pull-out subcuticular. So ideally, in a week's time or whatever, you pull the suture out. It can be a bit difficult on the skin pad. It tends to just snap in my experience, but if I just gradually pull it out, it will come out. It's a bit easier in reality. Well, it's coming. The wound should reopen. So it comes out quite easily. I also use a monofilament suture for this so that it glides nicely. The braided suture entangles a bit too easily. And I typically would do this on the face, like the eyelids. If someone has eyelid surgery, you don't have to do any deep dermal. You can just put a pull-out suture. So that's closing a deep wound in that fashion. And then let's just revise those techniques we talked about yesterday to take tension off of a wound. If you have any questions, Anthony, feel free to ask. So the first one was the slip knot. You go across, pull it through, palm your forceps, wind the suture with one hand. One, two, pull the suture. You know it's gonna unravel. So let's say it does this. Rather than undoing it, wrap it round like a reef knot. Pull the short suture through. Don't move the long knot, the long suture, and just pull the short suture till the wound is closed. The wound is closed. So I'm now going to pull the long suture. And then just carry on. The monofilament, so in theory between 4 and 6 knots, but it's just skin, so you can always get away with 4 as long as that they are lying properly. And by that, with monofilaments, you just need to be careful because proline and things like that have memory. You need to make sure the knots are sitting on top of each other like that, rather than gaps in between. And then you cut, that's the slip knot. The other technique is to lock the knot to start with, which also happens to slide it across to one side in the first place, which is good to do. No, you can't see what I'm doing. Let's go this way. So we're just going to do the locking knot. 1, 2, which is the surgeon's knot. Slide it down, throw it across. That didn't hold. Slide it down, throw it across. That didn't hold. Let's see, one more time. Slide it down, throw it across. That did hold, and carry on. It's because there was a piece of suture in my way. But if that didn't work, I would just do a slip knot, then cut. And then the last technique was to hold the tension with a semi-hand tie type maneuver, which is, and I also do that when I'm stitching at depth. I do this technique when I'm stitching at depth, and I don't want to have to go looking for my short end of suture. So you go across. One, two, grab the tip of your short suture, finger tight, go overhand, take your index finger under the long suture, short suture on top, and squeeze the cross. So that's there. You make the cross, squeeze the cross, go under this loop that's visible over your finger, and pull the short suture through. But the tension is still squeezed between these two fingers. And you pull it down. And that way, if it's a gaping wound, you would have kept the tension of the wound closed between your finger and laid the knot with the wound closed. I'll do it one more time. go across. It's a long needle, so I can go across in one. Big bites. Grab the body, not the tip. One, two, finger tight. So you don't have to do all this and all this. It's just your finger goes down. Put your finger underneath. Make the cross and squeeze. The short sutures there. Go through the loop, bring it through the loop. The tension is all in the needle holder and let go with my other hand. The wound remains closed. Pull the long suture, and then lay your secure knots. So those are my techniques for wounds under tension. And then the next thing we need to cover is how to hand tie. So for that, I'm going to use this jig. I think suture is easy to see. So you always have any questions? If you have any questions, of course, pop them into the chat and I will answer. You always have a short end and a long end. It can be as short as you want and as long as you want. Usually a big suture, and it's good because you can tie at depth and you also can control the wound tension a bit more. Whereas when you're using a needle holder, sometimes you can squeeze it so hard that it just fractures the suture. So the two-handed hand tie, what we'll do first, then we'll do the one-handed hand tie. I think one-handed is great if you're left-handed, one-handed is also quicker. If you find this easy, do it with gloves. If you find it easy, do it with your eyes closed and do it with gloves. So pick up the suture with your index and thumb hand on top and roll it. It's going up. And then pick up the other suture with the other hand and come down your three fingers. So this one goes up four fingers, this one comes down three fingers. At all times, you must have a short suture and a long suture, one suture going up, one suture going down, and they can never go in the same direction at the same time. They always have to alternate their position. You go over the long, so this is the long, you go over the long, under the short, and squeeze between your middle and ring, and pull it through, and tie it tight. I won't tie it too tight because I have to undo it after. So this was my short suture that's now gone up. It now needs to come down. So I turn my hand down and move my thumb down and hold the short suture between my thumb and ring. I separate my index and middle, and I'm like this. So it was like this. I've now opened these two fingers out. I do that because if one suture is coming down, the other one has to go up, and it's going up these two fingers. It always goes over the middle finger, regardless of the rest. Over the middle, under the short, and squeeze now between these two fingers. Before it squeezed between the ring and the middle, now it's squeezing between the middle and the index. You squeeze the suture, the short suture, between these two fingers. When you have it here, you let go of it here. And then you put it through the suture, the loop. And then you repeat. You go up, so up the hand, down the hand, flex the middle over the long, under the short, and squeeze between the middle and the ring, and pull. And then you come down. Separate. This is coming down, so this has to come up. And squeeze. And then you go again. Going up, going down. Going down, coming up. And then you just keep going. Now you have to assess your knots and make sure that they look like this. What is this, I hear you ask? So this is a macroscopic view of the same way your suture knot should lie. So what you want to see is this figure of 8 type pattern. When you're doing this for, closing off vessels and things like that, what you want it to look like is this. The sutures are flush on top of each other. You don't want these holes. Same for when you tie your knots when you're suturing. If you tie knots that leave holes, the vessel will start to bleed again because you clipped and cut it, but the knots are not secure because this suture will unravel with time before scarring and hydrolysis takes place if it's dissolvable suture. or it would just unravel even if it's non-dissolvable, because this is not secure. So you have to really make sure you push that short suture down. So that's the two-handed hand tie. And you know that it's been laid correctly because you don't have two sutures in the same position on top of each other. It goes here, then it goes here, then it goes here, and then it goes here. That's why it's useful to use two-colored rope. So now we're going to do the one-handed hand tie. Any questions? It's okay if you don't. I know it's late for you there, so I appreciate you logging in for the session. I hope you're finding it useful. No, very good. Good to hear. So now we do the one-handed hand tie. So the one-handed hand tie is fairly similar, but you're just using your index finger really. So go up. This suture kind of stays the same the whole time. Goes vertically up. Bend the middle over the long, under the short, and squeeze. You have to alternate position. You alternate position, but this is actually what I do. Sorry, I lied to you. I've told you a complete porky. So you're in this position, going down through. You bend the index finger over the long and push the short one through the loop. So it's a quick maneuver over the long, flick the short suture into the loop and pull it through. But you still have to do going up and going down throws. You have to alternate positions, but the long suture stays exactly where it is. If you do two of the same thing, it will not look correct. So you can assess that because you want the same as before. You want to see if you hold the suture still, you don't want to see a continuous suture going all the way up. You want to see one here, one here, one here, one here, one here, one here. So you always have to do a going up, going down, but the long suture just stays taut. So it can be in any direction, but it's just the short suture or your left hand doing the hard work. We'll do that again. I think it's useful when you're using really thin suture rather than rope. So if you're using an O or a 1 suture, you can two-handed hand tie. But when you're using like a 3 or a 4 and you're hand tying, I think the one-handed is probably superior. So we're here, same as before, but this comes back to the vertical position. And you're here, so it's between the middle and the thumb that hold this suture. You meet it, you flick it through, and you come down. But this is the real key. Push that knot all the way down. And again, and push that knot all the way down. So everyone's laying flush with each other. Push the knot all the way down. The short end is the one that really has to move. I think the best way to practice this is just to put a shoelace on every door. Every time you go through the door, you have to do a knot. Getting a bit short here. Final one. And then we can assess it. Still, let's have a look. You can see if we've got any non-square knots. Yes, we do. So we're going up here, here, here. And I've done two of the same thing here, which isn't correct. And then here, 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 here. So this is not correct. This is not secure. This is two of the same thing. That's not right. That means I've done the same direction twice. And that's how you can see. Great. So, what we have covered today, closing wounds under tension, the deep dermal. We have had a process in terms of how to do that, starting in the apex and working towards the point of most tension rather than starting straight back in the middle. You can put a suture in the biggest point of tension temporarily to take off the tension once you put the deep dermals in. And then you just need to decide which technique you're going to use to close the top. I think if you're going to do a nice long linear wound, a subcuticular works well. If you've done a very, very good deep dermal, like you said, you don't have to put anything on top. You can just put some glue and some steri strips, but I think you shouldn't leave it to chance. Maybe put a pull through subcuticular. Patients want to come back to the doctors to get the wound checked in. Just put a subcuticular and bury it. We did yesterday. Suture selection is important. I typically will use a braided suture for my deep dermals if it's under tension. If it's not under tension, a monofilament's good. If the patient's got good dermis, then again, a monofilament's fine. You can use braided sutures, you can use barbed sutures, which means that you don't have to have any knots. And then finally, we've done hand ties, one-handed and two-handed. I hope it makes sense. Which one you use is really down to you. I think most surgeons typically use the one-handed, but nobody really cares. Just choose which one works for you and do it consistently and make sure it works well for you. You typically will use, for tying off vessels, a dissolvable braided suture like Vicryl. It either has the needle on it or it doesn't have the needle on it. If it has the needle on it, you transfix it. So you go through the lumen, then you go around it, and then you tie it. If you're just doing ligation, you just clip, clip, cut, and then tie around the vessel. Yeah. The transfixion is where you go through the lumen and tie it, and then tie it. Just ligation is clip, clip, cut, and tie around it. Any questions? I think we can, yeah, yeah, sure. So I don't have two artery clips, but I do have. So what you would do is, if this is your vessel, just going to do a demonstration of how to tie around the artery clip. So clip, clip, and then you would cut. Then your assistant needs to show you the tip of the clip. And then you take your suture. I'm just going to find one. I haven't cut this, so it might be a bit difficult, but anyway, there we go. So the nurse will give you your clip. They show you the tips there. This would be a free end. You go around. Go around under the clip. They keep the clip on and up. You would have cut that in the middle already. And then you hand tie. And you just have to make sure that it's robust. So at this point, you can say to them off or ease and squeeze. Off means you just come off and it should be closed. Ease and squeeze means you come off a little bit and then you re-clamp, which allows the person that's tying, when they come off a little bit with the ease, to re-tighten it and really make sure it's clamped off. Yeah. So you have off completely and then you have ease and squeeze. So the trick is you clip, clip, then you cut, and then you wrap the suture underneath the artery clip, not in front, and you tie the first few knots, and you say off or ease and squeeze. The off is after the first knot. Ease and squeeze is also after the first knot. That's just ligation around the clip, and you should see really see anything here because the suture is very small, but I'm using a Vicryl to do it. That makes sense. And then you want a purse string. So a purse string isn't for an elliptical wound, it's for a circular wound. Um, I can make a circular wound. However, I'm not sure the skin pad will hold the suture, but we can try. So elliptical wounds, you make an elliptical wound because when you cut out the lesion, if you add most lesions are circular, not elliptical. You cut make things elliptical because you want to close it directly. But with a wound like this, let's say I know that it will never close, but I can narrow it. Patient doesn't want a skin graft, or I want to use a smaller skin graft. I can do a purse string. So I mark the lesion, I add my margin, but I do not make it into an ellipse because it's not going to close primarily. So let me uh, let me cut out this lesion and do it like that. We can do it on this. I'm going to show you the principles of a purse string, but I'm not expecting this skin pad to be able to purse string because I think that may be asking for too much on the skin pad. You sweep from one side to the other so that your depth is the same on all areas. So what I'm not doing is this. I'm just sweeping from top to bottom. And then once you get round, just releasing the edges, sweep from top to bottom. And then you get your lesion. So I know that this is not going to close because there's not enough laxity. I'm just going to do a purse string. This will not, this tissue, this skin pad will not purse string, but I'll show you where the placement of the suture goes. I'm going to use a dyed suture just so that you can see how I'm doing that. I typically use a braided suture for my purse strings because I know that they're under tension. So the purse string goes in the dermis. And you just start in one area and run a subcuticular essentially all the way around. I go back on myself a little bit, and it's a dissolvable suture you do to do it. I tend to use a long-lasting braided suture like Vicryl, and you just pull. I do purse string sometimes when, let's say, for example, I'm doing skin cancer excisions and I am putting a skin graft. I know it needs a skin graft, but I only have a full thickness skin graft. I don't have a Watson knife. I don't have a Humvee knife. I don't have a dermatome to take a split thickness. So I have to take a full thickness. So because with the full thickness, you have to be able to close the donor site directly. I might purse string the defect so that I can now take a full thickness skin graft rather than needing a split thickness skin graft. I also purse string wounds that, like on the legs in elderly patients, we know that they don't heal very well. So if I purse string it, it just makes it slightly narrower and may heal a bit quicker, but it will still take a while because the sutures will dissolve and the wound will reopen a little bit. And I just go back on myself. You really need to be able to go from the palm grip to the mounted grip. And the key is mount it straight away. I'm optimistic that this might actually part the purse string, to my surprise. I've never tried it on a skin pad before, but hey, and I'm also using a monofilament suture, which I won't typically do in reality because I want it to have grip and I'm going to pull quite hard to narrow the wounds. I don't want it to cheese wire out. So that's why I use a braided suture for my purse strings. And again, I go back on myself. You can see how my hand position literally just I don't move myself. I literally just move how I hold the needle holder. You want to get a good bite through the tissues, going in all the way around. Not in the fat, just in the dermis. It's like a subcuticular, really. And then you come out just before where you started. This is a situation where where I usually actually will hand tie, because I just want to have control of my closure. Again, I'm not expecting this to work too well. Yeah, like that. So it comes out. But that's how you do the purse string, and then I tie it. Make sense? And it will narrow it reasonably. And then it's dissolvable, so you just cut it flush with the knot. How was that? Is that all right? Make sense? Great. Any other questions? Unfortunately, if you're you wouldn't do a purse string on an elliptical wound. The elliptical wound is just for primary closure. Let me just read what you said again. Oh, okay. I see. Three different things. I see. Uh, I mean, in theory, that big gaping wound I did was the elliptical wound, right? So no, so the elliptical wound was this big one under tension. So it really just depends. If I cut out this is a long elliptical wound right here, if you see. So it depends. If it's not gaping, you have two different types really. You have this ellipse, it's a long ellipse, and this one, which is a slightly less long. I probably would put a deep dermal. Wouldn't probably. I would put a deep dermal in here, and then for this length, subcuticular. If it was a short ellipse, just interrupted. If it's in trauma, interrupted. If it's elective surgery, skin cancer, the skin all looks very normal, just subcuticular. I think it's nice, neat surgery. For this, I put deep dermals the whole way and then do the subcuticular on top. The choice of sutures that you use is really just dependent on the wound you've got. You can use anything you want. I would do the deep dermals for the tension. And then if you want to do interrupted on top, you can do interrupted on top. That's absolutely fine. I just think it's a lot of continuous cutting and stitching and cutting and stitching. So just using a one suture is fine. But if you have a short ellipse, absolutely interrupted is fine. Just the balance between what's going to close the wound and what's quickest. Does that answer your question? Okay, great. Any other questions? Anything else I can show you? No, I think we will call this session on a close. Okay. Yeah, me too. Don't worry about it. I also have a tremor. And if I've had a long day and I've drunk a lot of coffee, it's even worse and it's worse during micro. Doesn't matter. Ignore the tremor. Keep your forearms based on the surface and keep your elbows tucked in against your body. If you're happy with the tremor and it doesn't bother you and you're confident in your technique, the tremor shouldn't make a difference. I have a tremor, and like I said, it's worse during coffee, but if you're so focused on your task, it's irrelevant. Some people don't have one. Good for them, but it's okay. I have one too. Doesn't change anything. Just keep practicing, keep working, and be confident in your skills. On that note, yeah, absolutely. And also, the tremor also gets worse when somebody is watching, I find. Um, the more senior the person watching you, the more likely you are to have a tremor. But that's okay, as long as you know what you're doing, like you say, it tends to get better. I hope you have a nice evening, and I think I'll catch you next on the tendon repair session on the weekend. Have a good evening.